Bismillahirrahmanirrahim. Let's start with the paliperidone long-acting injection. So, uh, it is the formula of the paliperidone long-acting injection is 9-hydroxy uh, paliperidone or 9-hydroxyrisperidone, I think. So that's the formula of paliperidone. And then that is an active metabolite of risperidone. It's not a precursor of risperidone, but a metabolite. And then paliperidone palmitate is the ester, which is the compound which is there in the depot injection. So that is paliperidone palmitate. So usually these decanate or palmitate, these long compounds are usually take the role of the injectable antipsychotics. And then this is absorbed. So it's hydrolyzed by the esterases in the muscles and then absorbed in the systemic circulation. So what happens is usually the oil-based depots, they were deconates, and then uh, because they are oil-based, so they stay there and they are slowly absorbed. Here it is slightly different in case of the risperidone depot and paliperidone depot and the newer kind of atypical uh, antipsychotic depots. And how it is different is that they are usually polymers, and these polymers are then hydrolyzed by the esterases by different enzymes uh, and into smaller compounds, and then they are absorbed into systemic circulation. So that may take the full absorption may take 1 month, and if you give higher doses and maybe adjust the formula a little bit, then it may take place within 3 months as well. And we will come to that. So let's talk about the monthly paliperidone injection. So the loading dose is given. Usually what happens is that you give the test dose of any conventional depot. You give test dose first, and then if the test dose doesn't cause any reaction, then you give the loading dose. Here it is opposite. Because in the test dose in the older depots, you are checking the sensitivity to oil as well. But here you're not checking the sensitivity against oil, the allergy to oil. So all you are checking is because they are hypoallergenic. I mean, they can cause allergy, but the chances of causing allergy are relatively less as compared to depot. So it is the compound itself, the active ingredient itself, which will cause the allergy or which can cause the allergy. So, so what we do is that we give the loading dose first, and then and then the regular dose. But before loading dose, it is wise enough, and I would say it is at least 3 days of oral. I would say it should be must. Unless the patient is known to that drug in the past, then that's fine. But if the patient is drug naive and if the patient is, especially the patient has not taken that particular antipsychotic in their lifetime, then always go with the oral challenge first. Give them oral for a few days just to check that they are not allergic to the medication and they are not sensitive to side effects such as extrapyramidal symptoms or akathisia, etc. And if you are comfortable that they are not that much sensitive, then maybe you can go with the uh, with the injection then. Uh, so so the loading dose a few days to peak level. So it will take a few days to come to the peak level. So paliperidone palmitate long-acting injections, 9-hydroxyrisperidone. That's an active metabolite of risperidone. Paliperidone palmitate is the ester prodrug of paliperidone, available as a monthly and a 3 monthly long-acting injection. The ester is hydrolyzed by esterases in the muscles to paliperidone, and then that is absorbed in the systemic circulation. So let's talk about the 1 monthly paliperidone injection. So plasma levels are seen within a few days usually. And initiation dose. Now, where do we give the first dose? Like, Asad, do you give the first dose into deltoid or do you give it in the gluteal region?
Sir, first two doses always in deltoid, sir.
Yes. Okay, so the first two doses are given in deltoid region. And then after that, the first, like the second monthly dose or monthly maintenance dose can be either in deltoid or in gluteal. So that's another kind of advantage over the traditional. If the patient doesn't want his gluteal muscles, they can get the injection in deltoid as well. So the first dose is 150 milligrams stat, but in elderly, you may reduce it to 100 milligrams because the maintenance dose you are giving less. So usually you give the maintenance dose as 100 milligrams deltoid, and then again another 100 milligrams after months and after a month, and then after every month. It can range plus minus 4 days, plus minus 7 days. So if the patient has missed the depot, you still have 7 days. Like you can, it's 4 to 5 weeks, but usually you have to give it every 4 weeks. And now you know that the patient has missed, try to give it within a week. Similarly, if the patient is traveling to another country, then maybe you can give 1 week early if he's traveling within a week, before or after. If it is after, then maybe you can give, uh, you know, if like in the routine on the right days. But if the patient is traveling the week before the depot, then maybe you can give early depots. Similarly, what we do is sometimes we give the maintenance dose, like if the patient is admitted and now there are like the bed pressures that there are, like the patient is stable now and you have to discharge the patient, you have to admit more risky patients instead of him or her. So the patient's depot, let's say, was due on 26th of September, and you need urgent beds on 23rd or 24th of September. So you have the option to kind of give it is 3 or 4 days early, and this is right with the as like it's right with the olden, like the typical or conventional LAIs as well. You can give the dose a little bit early or a little bit late according to the availability, because like if you give it early, there is a likelihood that the patient will be stable in the community, but and the community nurses will also be relieved that the patient has taken the depot in the hospital, because hospital environment is the ideal environment to get the depot. So maintenance every month plus minus 7 days thereafter, 50 to 150 milligrams intramuscular, deltoid, or gluteal. So you can give 50, you can give 75, you can give 100, 125. and care is required in patients who get more hyperprolactinemia on higher doses. You can use lower doses in them, or patients with hepatic or renal impairment, or learning disability population, or elderly population. Risperidone 2 milligrams is equivalent to, I think, paliperidone 25 milligrams fortnightly. Paliperidone, Asad, does that come in Vega? Does that come in 4 milligrams or 3 milligrams? Can
Sir,
you
3.
3? Yeah.
Yes, sir.
Okay.
3, 6, and then of course we can go up to 12. Mean the maximum dose.
Yeah, yeah. So risperidone 1 milligrams.
Sorry.
Yeah. Okay. Okay. So yeah, risperidone 2 milligrams will be equivalent to paliperidone, then maybe 3 milligrams. Is that right? Because two fours are 8. Anyway, it is 3 to 4 milligrams. And then 3 milligrams of risperidone will be paliperidone, uh, around 6 milligrams. Risperidone 4 milligrams will be equivalent to paliperidone 8 milligrams. And risperidone LAI 50 milligrams. So, I mean, you can give the depot at 25 milligrams fortnightly if it is the risperidone depot itself. And then if it is the paliperidone depot, then you will give it 50 milligrams monthly. Similarly, risperidone 3 milligrams. So paliperidone will be 6 milligrams. Risperidone LAI will be 37.5 milligrams fortnightly. And paliperidone LAI will be 75 milligrams monthly. Then risperidone, if you are giving 4 milligrams, then paliperidone will be 8 milligrams. Risperidone LAI will be 50 milligrams, and paliperidone LAI will be around 100 milligrams monthly. So that's how you calculate the equivalence. And risperidone 6 milligrams, if you're giving, then uh, risperidone consta, you have to give very high dose, but you can still give the paliperidone 150 milligrams monthly. Now, pearls of practice. So there's no test dose needed for extremely non-compliant patients. For example, if the patient is has been admitted and he's not taking tablets, he's absolutely refusing all oral and injectable antipsychotics, and he's a risk to himself and others. So he's a risky patient. In that case, if the patient is that much risky, then what? But you have to give him something. Now, the patient is known to risperidone or paliperidone before. At some time, he has taken risperidone or paliperidone. In that case, you can give him the loading dose straight away. But if the patient has not taken risperidone in the past or paliperidone in the past, and you need to give him something, then it is better to start with the test dose. It's very exceptional circumstances that you will give the test dose of the second generation long-acting injection. But in those cases, it is better because the patient is not exposed to the compound in oral ever in his life before. So maybe you can give uh, kind of 25 to 50 milligrams of paliperidone injection, and if the patient is okay, doesn't show any untoward effects, in that case, then you can go ahead with the with the something you call a kind of the full loading dose of paliperidone, and then the maintenance dose. So whatever it's needed, loading dose can be 150 milligrams, and then the maintenance dose is usually 100 milligrams monthly. Is it clear? Okay. Now, if it is the first time, so stable the patient on oral risperidone. Ideally, but not necessarily. Ideally, stabilize the patient on oral risperidone and paliperidone, and then give the loading dose and then the maintenance dose. And patients who have responded to a known dose of risperidone or paliperidone, you can determine the dose of paliperidone you will be using. So what uh, what will be the dose of paliperidone you will be using in the future will be determined by what dose he was on before, what dose of risperidone. So, for example, if he was on risperidone 2 to 3 milligrams before, then he will need the paliperidone 75 milligrams monthly. Now, the side effects, hyperprolactinemia, it's more as compared to haloperidol, more weight gain because it is atypical antipsychotic, so more weight gain as compared to haloperidol. But the good thing is less extrapyramidal symptoms as compared to haloperidol. Sometimes akathisia can occur to, due to the due to their second generation or atypical antipsychotics as well. Now, how to switch paliperidone monthly injection from no treatment? If the patient has no treatment ever, no risperidone, no paliperidone, then start him on oral. If he is refusing oral, then give him a small test dose. Then start with maybe after a week of the test dose or after a week of the oral treatment. Then you start with the 150 milligrams loading dose of paliperidone. Then after 1 week, you give the 100 milligram maintenance dose. If a very high dose is required as a maintenance dose maximum, then you can go with 150 milligrams maintenance dose as well. If a less dose is required, you give 100 milligrams loading and 75 milligrams monthly. From oral dose, continue oral risperidone or paliperidone at least for 2 weeks after the loading dose. And then other antipsychotics, so give depot at the day 1 and day 8, and then 1 month after that, taper down the oral for 2 weeks. So if we are giving it, if we are switching onto the depot from other antipsychotics, then continue that other antipsychotic at least, for another 2 weeks, and then after that 2 weeks, then start tapering it down. So very similar to that of risperidone oral. If we are switching from one depot to another depot, for example, zuclopentixol depot to risperidone depot, start with the desired maintenance dose when the other depot was due. For example, Sayyida, if let's say uh, like a very posh class patient come to you, they're very much affording, very affluent, and let's say that paliperidone depot has become available in Pakistan. Patient is non-compliant to the treatment. So you have tried the patient on oral risperidone before many times, and he doesn't show any side effects on oral risperidone. What you can do now, the patient, let's say, is stable on zuclopentixol, maybe 600 milligrams or every 2 weeks, or 500 milligrams every week, etc. And he's getting terrible side effects. He's getting akathisia and maybe other Parkinsonian symptoms as well. And you feel that he needs an atypical depot. So how to how you will switch is that the patient was due on zuclopentixol 500 milligrams on a certain day. Let's say 25th of September he was due. So, and you were giving it every 2 weeks. So 500 or 600 milligrams was due on 25th of September. Before that, it was given on 1st of September, actually 10th of September, if it was every 2 weeks. So now on 25th, you miss the dose of zuclopentixol, and you know that the patient is not sensitive to the compound of risperidone or paliperidone before. So you can straight away give the 150 milligrams desired maintenance dose at that time. This is according to the Maudsley prescribing guidelines. And then you stop the other depot. Then the next week you give the risperidone, the the uh, the maintenance dose after that. Or rather than giving loading dose, I think the Maudsley prescribing guidelines, they are focusing mainly on the desired maintenance dose. So you can start with the desired maintenance dose actually of 100 milligrams when the other depot is due, and stop the other depot. So it's very simple. You don't even need the loading dose. Just start with the maintenance dose. And you can give some oral alongside for a couple of weeks if you want. Antipsychotic polypharmacy with injection paliperidone and other antipsychotics and other way around. So give the desired maintenance dose of the depot paliperidone. Stop the oral gradually. So if the patient is on oral haloperidol, then you can give the kind of maintenance dose and then stop the oral medication quite gradually. Now, paliperidone long-acting injection 3 monthly. That's a new thing. Like it came to the UK and Ireland only kind of 6 to 7 years ago, and in Ireland it's quite uncommon. It's in the UK it's even more uncommon. So 3 monthly injection, patients who take monthly injection for at least 4 months. So the patient has to be stabilized for at least 4 months on the monthly injection of paliperidone. Once they have taken 4 injections and they say they don't want needles every month, they feel uncomfortable with the needle being pricked every month, or patient says that he has to travel abroad every kind of every month or every 2 months, and there is a chance he may miss his depot, but he can make sure that he can come back within 3 months. For those patients, 3 monthly depot may be appropriate, but I mean, reserve it for only exceptional cases who really need it. Otherwise, monthly depot is the ideal. So 3 monthly depot is less than ideal. Only patients who are extremely non-compliant and who agree to get pricked every 3 months, and that too after 4 months of monthly injections, you can choose, or the patients who go abroad every time. So it's well tolerated, and tolerability is similar to monthly paliperidone. Now, there are reports that the patients clinically do better on 3 monthly injection. The advantage of 3 monthly injection every 3 months, less number of injections, less hassle for the patient, less local injection side effects, for example, cellulitis, bruise, etc. There will be less chances of that. But there are reports that some patients get relapse or get breakthrough psychotic symptoms within those 3 months, let's say at 6 weeks or 8 weeks. So it is important that the patient still remains in contact with his community psychiatric nurse every 2 to 3 weeks. Even though they are getting the injection every 3 months, they should get in touch with their community psychiatric nurse every 2 to 3 weeks. And then less frequent contact with the healthcare professional may be a problem. If it is less, if they're not contacting, or if the healthcare professional or the community mental health nurse is not contacting them, then that may be a problem. So the patient should see his care coordinator or CPN still every 15 days or a month. Dose equivalence. So if it is 50 milligrams monthly of monthly paliperidone, then it will be 175 milligrams of 3 monthly paliperidone. And if it is 75 milligrams monthly of paliperidone, then it can be 263 milligrams of 3 monthly paliperidone. If it was 100 milligrams of Zaplion you were giving, then the Trivecta you will be giving is 350 milligrams every 3 months. And if it is 150 milligrams, then you will give 525 milligrams every 3 months. Shake well before administration. So the dose equivalence is that you multiply by 3.5. So a little bit more you give than it is exact, like than the three. So 3 monthly, but you give it 3.5 dose, not 3 times the dose. So that's about paliperidone monthly and 3 monthly injections. Any questions? Any questions, Dr. Asad or Dr. Ahad? No?
Sir, just one question. It's a query as well. In terms of, sir, the special consideration for pregnant women.
Yeah.
Mean, does the the local guidelines or the FDA approve in those special cases that we can go ahead and inject them the monthly or 3 monthly? Exactly. I mean, if they need it.
I mean, I have very little experience in the perinatal psychiatry, but in extreme, I mean, usually the safest antipsychotics in pregnancy is haloperidol, or otherwise the quetiapine amongst the atypicals. So I would, you know, being on the safe side, I would switch the patient on monthly haloperidol injection if the patient is non-compliant. If they are compliant, then maybe oral haloperidol or maybe oral quetiapine. I think haloperidol will be much better. Risperidone may be unlicensed dose we can give, but after discussion with the perinatal psychiatrist and after going through the guidelines, if risperidone is safe enough. So, uh, so in very extreme cases, and very rare cases, maybe somebody might have continued the Zeplion or the paliperidone monthly injection. I don't know about if that has happened or not.
Right, sir. Thank you very much.
All right, so we close here. Thank you very much. See you in the next session, inshallah.
Thank you very much, sir. So nice.
Thank you, sir.
Thank you.